Oh my goodness, that was quite the introduction. So thank you, Reverend Ron, and thank you to all the Norton Cancer Institute leadership and staff for having me today and for your commitment to cancer care, and a big thanks to the Nixon family for your commitment to upholding this community that cares for patients and their families in such a critical time of their lives. I have the privilege of caring for cancer patients day to day. It is what I love research. I love writing articles and working on research teams, but when it comes down to it, what I love is taking care of patients. And I'm sure for those of you here who have the privilege of providing patient care, you understand what that is like. So this is what tonight is clearly about. I see that as I spoke with the Nixons. I see that in the video, in the introductions thus far, that you all are about really truly embracing and upholding patients and their families as they face a cancer diagnosis. And giving them the best possible opportunity for cure, but if there is not the opportunity for cure, to give them the best possible care to live in the best ways that they can. And so that's what we're going to be speaking about today. In many ways, I feel like I'm going to be a cheerleader to a team that does this already, but I think we all need encouragement, don't we? Yeah, to continue doing what we're doing, to dig deeper in bigger ways, especially because inevitably there are challenges. I understand that you all have been expanding with other sites and hospitals, and of course that always comes with many opportunities, but also challenges. And so it's so important to continue to be grounded and to be encouraged in the fundamental calling that you all have as a community that cares for patients. So I'm speaking about whole person care and spirituality, and in particular, how spirituality plays a critical role in enabling whole person care. And we'll see that in the ways that it impacts outcomes in serious illnesses, including cancer, and then also even in the health setting, in healthy populations. I'm just providing my disclosures today. And I'm going to start with two patient stories for all of you. Again, it's always most helpful, I think, to be grounded in our patients' and families' experiences. But this first gentleman was a gentleman in his late 50s with metastatic prostate cancer, receiving palliative radiation therapy for painful bone metastases. This isn't his actual photo, it's a stock photo, but he said this to us: you know, if it weren't for my faith, I don't know how I would have kept my equilibrium through this process. And he went on to share how his faith was central to his ability to manage the many stresses of his illness, as well as that of as for his family. Here's another patient. This is a gentleman in his 70s who hadn't seen a primary care physician for many years. And was coming for the first time to see a new primary care physician. And as part, that primary care physician did a spiritual history as part of a social history, learned that he attends a Catholic Spanish-speaking parish, but hasn't attended since his wife died 8 months prior of a metastatic cancer. And his church community is actually bringing him meals twice a week, and a fellow congregant is actually the one that brought him to this appointment. And because, you know, he hadn't seen a doctor for a few years because he was caring for his wife with her metastatic cancer diagnosis. So these are just two very simple, everyday examples of individuals facing illness, a caregiver, as well as a patient, and how spirituality just intertwines with that experience. I do want to pause and take one moment and consider definitions. It's important for us to understand what we're talking about as we talk about spirituality. So first, what is spirituality? It must be very broadly defined in order to capture the myriad forms that it can have across individuals, across cultures, et cetera. So Christina Pekalski, who's really a leader in this field, drew together international leaders who set forth this definition for spirituality as a dynamic and intrinsic aspect of humanity through which persons seek ultimate meaning, purpose, and transcendence, and experience relationship to self, to others and the significant or sacred. Spirituality is expressed through beliefs, values, traditions, and practices. So you can see in this definition it's very broadly defined, can be expressed in more traditional ways or can be expressed in more non-traditional, non-communal ways. And of course, religion is a very related term. It's generally understood as a set of spiritual beliefs that are actually shared by a community of persons, typically with common writings and practices. So having set these definitions, let's consider a roadmap of where we're going today. And first we're going to be considering the historical relationship of spirituality and the practice of medicine. And why am I doing that? I'm doing that because, in general, spirituality and the practice of medicine are quite separated from one another in this current time. There's some places of integration, but often quite separate. That hasn't always been the case, and we need to understand what things were like in the past and why we are where we are today in order to be able to engage with some of the barriers to being able to integrate and embrace the spiritual health of our patients. Next, we'll consider the implications of this current relationship of spirituality and the practice of medicine to our patient care, to our patients, to us as caregivers of patients, and then also to institutions. And then finally, I'll turn to evidence regarding spirituality and its role within serious illness, as well as its role in healthy populations. So we'll begin with this historical relationship. Bear with me, we're going to do this very broad strokes overview, but I think, again, it's very important for us to understand the backdrop of why we are where we are today. So when we consider the history of Western biomedicine, which is what sort of is the historical backdrop of the practice of medicine today, typically we begin with classical antiquity. And of course, it was during classical antiquity that we had the worship of Greek and Roman gods. And we readily see how the practice of caring for the sick and the spirituality of that time was very much integrated with one another. And that's beautifully illustrated in this John William Waterhouse painting of a mother bringing her sick child into a temple of Asclepius. Asclepius is, of course, the god of medicine and was worshipped during this time in these temples of Asclepius. So here is this mother bringing her son to this temple of Asclepius. You can see the priest performing some sort of sacred ritual. And it was actually in this setting that there was also bodily practices of care as well. In fact, individuals would often stay for these sort of bodily practices, as well as very much a spiritual practice, as we can see here in this image. During Greek and Roman times, we have the rise of Hippocratic medicine, and Asclepian and Hippocratic medicine were really concurrently practiced. And of course, Hippocrates, who's considered one of the fathers of medicine, set forth this, at that time, novel idea that illness is the result of a bodily cause or a material cause. In particular, the imbalance of the four humors: blood, phlegm, yellow bile, and black bile. But this is quite different than the previous thought that it somehow had to do with, curses from the gods, et cetera. It was very much a material conception of health and of illness. But it's interesting because that very material practice of medicine was grounded in the spirituality of the Greek and Roman culture, and we see that in the things like the Hippocratic Oath. So the Hippocratic Oath was recited in U.S. hospitals up till about the 1950s, when the language was changed and adopted to more modern language. But the original Hippocratic Oath, the way it starts, is, I swear by Apollo, the father of Asclepius, Hygeia and Panacea, Asclepius' daughters, and I take to witness all the gods and all the goddesses to keep according to my ability and my judgment the following oath and agreement. So we can see that this very sort of bodily practice is grounded in the spirituality of that culture. And I would just argue, we see, we kind of think of these things and, it seems like it's kind of up in the clouds, it's not really relevant to where we are today, but symbols have meaning to our culture. And what symbols do we see? Where do we not see the rod of Asclepius? Here I'm just providing you one example. This is the World Health Organization, probably the preeminent health organization in the world. And it's the rod of Asclepius. So we see vestiges of this history, of this connection with the spiritual connection as far as the practice of medicine throughout our symbolism in medicine. Going forward in time, we head into the Middle Ages, and it's actually during this time that we see the rise of the first hospitals within Western culture, and it's within spiritual communities. Again, the two are intertwined with one another, the care of the spirit, the care of the body. And bodily care, however, is still very much embraced in those spiritual communities. So you have them, the individuals in these spiritual communities studying, practicing, and transmitting ancient medical texts like those of Hippocrates, for example, and Galen. But bodily care was centered on spiritual care. They were always provided together. Just the fact that these hospitals were growing out of spiritual communities speaks to that reality. As we go forward further in time into sort of the high Middle Ages and then ultimately into the Renaissance, it's during this time that we, of course, have the rebirth of many of those philosophies of classical antiquity. You have the rise of empirical inquiry and the growth of the sciences. Of course, that comes from, you see the very familiar image by Raphael of the School of Athens, and you have Plato, who's, of course, the teacher of Aristotle, pointing up, because he's pointing up to the universal forms as the source of truth. And what is Aristotle doing? He's pointing to the world around him. The way that we understand truths about ourselves is by studying the material world and the world around us. And that is sort of some of the primary philosophies that drove this drive toward the study of the material world and the growth of the empirical method and the growth of the sciences. It's during this time that, I've been talking about how in these cultures the spiritual and the material were just, they just were intertwined with one another. But you begin to see the first examples of them being separated from one another. And one example of those is in Cartesian dualism. You start to begin to see that they're being driven apart. And then as we move into the Enlightenment and then ultimately into postmodernism from about 1700 to the present, we see not only a separation of the understanding of the spiritual and the material, but now a beginning of a zeroing in on the material and a sort of pushing away or out of the direct consciousness of how we understand the truths about ourselves, of spiritual understandings of who we are. So we see that in the growth of materialism, which is the philosophy that all we are can be understood, all truths about ourselves can be understood by the study of the material world. Reductionism, which is the primary tool of materialism. If we just break things down into all their component parts, we can understand truth more fully. And as a result of this, the empirical method really becomes one of the primary sources of truth for humanity. Of course, medicine grows in its material focus and care, and zeroes in on that and brings about such wonderful gifts. We now begin to truly understand the material processes that lead to illness. We begin to understand how we can begin to intervene, and we truly are empowered to make a huge impact on the lives of patients. So I don't want to say for a moment that these things aren't wonderful and beautiful gifts to us as humanity. But there was immediately a recognition that there was a problem. It's interesting to me how quickly it was recognized. This is a Enlightenment painter, William Blake, and this is a painting entitled Newton, so we know who the figure in this image is. It's a figure of Newton, and it's an interesting commentary on this development. This philosophical development, this focus on the material. Because here we have Newton, who is, what does Newton look like? He's this muscular, strong man, right? And what is Newton doing? He's looking down on these illuminated geometric forms. And we can see all the strength and all the good and all the light that's coming from what comes from the study of the material world, which is emblemized in someone like Newton, right? But then there's a commentary in the image, and that is, what is the figure of Newton seated upon? And what is all around the figure of Newton? And you see that what this painter is brilliantly doing is just making this commentary on, yes, there is so much that comes from our understanding of the material world, but even our study, or even our empirical method and our study of the material world is grounded on things that are outside that gaze. It's grounded on larger realities. It's seated on larger realities. So I say all that, and I now want to bring it to patients in that image, even to the experience of patients, to just show you how that, though the philosophy seems kind of up, perhaps not relevant to the day-to-day, but I would say it's more like the water around the fish that we live and breathe and experience, and impacts the culture of us as individuals and certainly systems. And I'll speak first to the experience of patients, and I'm going to share with you a patient of mine. Again, this isn't her image, this is an image from the internet, but reminds me of my patient, a 60-year-old woman who I met at the original time of her cancer diagnosis, and then followed her and cared for her multiple times over the course of her metastatic cancer diagnosis. And during, especially the last year of her life, she had multiple admissions to the hospital. And I actually saw, one of those visits, I saw her for the possible use of palliative radiation therapy. And she said this to me. We'd gotten to know each other quite well over the years. And she was lamenting the experience of being in the hospital. She hated having to come into the hospital again. And she said to me, I can almost hear this place telling me that all I am is a body full of tumors that are killing me. And we paused, and she talked about that she felt like all people saw was her body, and her body's falling apart. All these tests and people coming in and doing vitals and exams and all the rest. And she felt like that was injurious to her soul. That was her experience, because her body she's dying, it's falling apart. And she wants to be seen for who she is, not just being a body full of tumors. I would say that it not only can impact patients, it can impact clinicians, and I think Dr. Paul Kalanithi, the late Dr. Paul Kalanithi, who wrote this book, you may be familiar with it, When Breath Becomes Air, is a example of this. And so this book, When Breath Becomes Air, is the story of his training as a neurosurgeon. In fact, the first half of the book is dedicated to speaking about his experience as a training neurosurgeon, and then pivots on his metastatic lung cancer diagnosis, and then the rest of the book is about his experience now as a patient, going from a practicing neurosurgeon to a patient. And one thing that's so interesting in the first half of the book is you hear about him, and he's growing up, and he goes into medicine with all this desire to care for patients in a holistic way, to connect with them and to connect with families. But then this is what he writes. He writes quite a bit about his experience training as a neurosurgeon. But he describes this as his experience within training as a neurosurgeon. He says, some days, this is how it felt when I was in the hospital, trapped in an endless jungle summer, wet with sweat, the rain of tears of the families of the dying pouring down. I was losing sight of the singular importance of human relationships, not between patients and their families, but between doctor and patient. So here he is, he's getting trained in this system, obviously very intense training as a neurosurgeon, and he's with all this intention to really care for his patients well, but he feels like it's just being eroded through this experience of his training. And in my sense, especially myself having gone through medical training, is that we are so trained to fit ourselves and our tools and our gaze on the patient's material bodies in front of us, and the structures around us, the reimbursement structures, you name it, that reinforce that, keep us looking just at patients in this way, whether it's time limitations, those sorts of things keep us there and make it very difficult to extend our gaze into the larger picture of caring for patients. And it's not just injurious to patients, it's injurious to the clinicians who are caring for those patients. And I would say, it's those sorts of situations, like I can just imagine my patient and physicians like Paul Kalanithi just in the hospital all the time, dealing with that dynamic with one another, and losing connection with a key aspect of caring for patients, which is understanding them in a holistic way. So I sort of named how patients are influenced, how clinicians are influenced. I now want to turn to how whole healthcare systems are influenced by this fixed gaze on the material. So this is an old editorial written by palliative care leaders in the mid-1990s, published in the New England Journal of Medicine. entitled When Too Much is Too Little. You get a lot just out of that title. And it's speaking to how so often we give too much medical technology in the setting of end of life, in the setting of patients who are dying, and how that often is too little. And I'll just read this excerpt from this article to you. The experience with this patient is a disturbing illustration of the care received by many terminally ill patients in US hospitals, despite repeated requests that he receive no further life-prolonging treatment and that he be allowed to return home to die. The patient underwent a lung biopsy, 3 CT studies, daily phlebotomies, an insertion of multiple nasogastric tubes, as well as a gastrostomy tube. And he spent the last month of his life in the hospital. Recent reports suggest that his case, unfortunately, is not unusual. So this is an extreme case, and there has been much progress, especially with the palliative care movement, and to really change this dynamic. But I would say, and I wonder what other clinicians in the room would say, that this still happens. Care like this in varying degrees can still happen, where it's too focused on the material realities at hand and not capturing the bigger picture. And one thing that's quite sort of you have to pause and think about for a moment is you have to ask yourself, you know, here we're seeing what I would call dehumanizing care, dehumanizing to this person. Would you all agree? I mean, it's dehumanizing. Do you think any of the clinicians involved in this person's care intended that? I mean, aren't they all well-intentioned, working as hard as they can often, people trying to do the right thing, and yet they give care that looks like this? And you have to ask yourself, what in the world is causing these well-intentioned clinicians to give care like this? And I would argue it's this: if you're only trained to see certain things, if I'm not trained to look outside of it, if everything reinforces that this is the only way I see patients, then I'm not able to escape that pattern, and this is the care that results. And one could argue the most important thing is that it impacts the quality of life of the people we care for, patients, families, but what about the cost of something like this? If you just throw more technology, if that's all you're doing, is throwing your technology at circumstances like this, there's cost implications as well. So I just want to take a moment, and of course, and kind of maybe, encourage us all to dream a little, and maybe that's part of the purpose of this talk tonight is, especially because you guys have such a wonderful foundation, both in your heritage and in your current structure, to really think about this in a how to integrate spirituality into care in a really thoughtful way. Because it needs to be done in a new way. It can't be done in the ways it was done in the past. We live in a pluralist environment. There are new challenges that we need to face and then hence structure that care accordingly. But even still, I think it's important to reflect back and consider a time when spirituality was integrated to care and what that looks like, to kind of inspire us and to give us ideas, but understanding that in the current present day, it's going to have to look quite different. So this is an excerpt from a book by Gunther Risi, who's a medical historian, as well as a physician, who wrote this book, Mending Bodies, Saving Souls, A History of Hospitals. And you'll recall I said earlier that in Western cultures, the hospitals began within spiritual communities. And so much of the book is about the rise of hospitals within these spiritual communities. And he describes the experience of a person dying in one of those spiritual communities. And I want you to hear this and contrast it to that story in the New England Journal of Medicine editorial. First, the dying person confessed and then received the sacrament of extreme unction from the cleric who had heard confession and had absolved him. The administration of holy oil occurred on the bodily areas considered to be suffering. Some brethren remained with the dying inmate throughout the day and night, praying and reading from the scriptures by candlelight. The point of this vigil was to ensure proper passing. Nobody should be left to die alone. If death became imminent, the whole monastic community was summoned, and the monks congregated around the sick on both sides of the bed, alternately to pray and sing. So what a contrast to that New England Journal of Medicine editorial and story. And I'll say, when I first read this, I actually was an intern and had recently had an experience of of a patient who I was on night float and having to care for him. And of course I had many things I was being called to, but this man was dying and no one was with him. There was no family that was available to be with him. They'd been called, apparently they were gonna come soon. And I went to see him, but I was called many times to other things, and there wasn't anyone else other than me. I was the only night float person. And I had to go attend to other issues. And it was horrifying that this man was dying and dying alone, and he died alone that night. And it's just, in this story, we see such a different picture of care, where the structures are supporting something very different, right? When death became imminent, the whole monastic community was summoned. They had a structure in place. Who knows? They probably had some bell, you know. Everyone's got to be summoned. You need to come. You need to be present, and you need to sing. I mean, you see bodily care here, and I want to say again, we do not want, all they had was holy oil to, anoint the places suffering. We don't want just holy oil. We want our technologies we have today. But we also want care that embraces patients fully, that is present with them, that embraces them in all of who they are. And I would argue that in this image, in this story, where the patient is, it's not only embracing the patient, it's embracing the caregivers providing care to that patient. They are embraced at the same time. So this helps us, I think, to dream a little and to consider that care can indeed do these things. We can provide very technical advanced care, but we can be sure that we aren't so fixed here, and we can develop our skills to embrace patients and families in a holistic way. So to summarize, just to provide a little bit of a pictorial model for what's been said thus far, historically in the past, spirituality and medicine kind of grew together. So they were integrated just by nature of their having grown together. And that meant that care was very much integrated. But then what's happened over time is we have a division of the spiritual from the physical, and what that's resulted in is care that's very materially focused and can do harm to, at least can often neglect and even can do harm to the spiritual. So now I want to turn to a way in which we can begin to think about reintegration, and that's kind of the work that I've done, doing research work that helps to, it uses the language and the tools of medicine, in particular the empirical method, to begin to shine light on the role of spirituality in the experience of illness, in the experience of healthy populations, in order to help us to begin to see it, and then help us to begin to understand. That gives us a place to begin as far as how to begin to integrate and care for patients and families in that way. One of the sort of most comprehensive kind of projects that's been done in this regard was alluded to earlier. This is what's called a special communication report, which included, importantly, a systematic review, meaning, and I'll take you through this in a moment, we basically have combed all of the research literature on the topic over a long period of time. And I'll just give you some background on why it was done. First, there's been growing research that's been done on the role of spirituality, both in illness and in health, with some uptake into healthcare, but not much. And in part, that's oftentimes because much of this research isn't kind of necessarily getting into high-impact journals. But though there is some improvement, there tends to be a little bit of a bias against spirituality in the practice of medicine, and some important concerns as well. There's also some important, I think, new trends, and that is for the increasing recognition of a broader conception of health. We see that in the 1948 WHO definition of health, which understands health is not just about the physical, but about mental, social well-being, et cetera, not just the absence of disease or infirmity. And it doesn't speak to the spiritual, but definitely implies it to a degree. It then subsequently, in the definition of the 2002 definition of palliative care, the WHO actually names palliative care as including the spiritual as part of its definition. So more and more of an understanding that whole person care includes these dimensions of care. So the overall project goal then was that we needed to take all that literature, take the best of that literature, and provide a comprehensive assessment of it in two areas. One, spirituality in its role in ill populations, seriously ill populations, as well as in healthy populations. And then with a group of experts, actually have them distill down that evidence to what are the key evidence findings, and then also what are the implications of that evidence for the practice of medicine. So just to take you through some of the methods behind the project, this was about a 2-year process in which we began with the 2 systematic reviews that I mentioned over ultimately a 23-year period. Then gathering a Delphi panel to assess that evidence actually after it had been compiled. Then they're providing sort of qualitative feedback on what the evidence is saying, then a quantitative assessment on the strength of what the evidence is saying, and then finally kind of a summary of all of that evidence to give us sort of key evidence statements that are supported by high evidence, by strong evidence, and then also the implications for the practice of medicine. So this is just to speak a little bit to the systematic review itself. We included many different key kind of research databases. All of the research was screened by 2 people who were blinded. It was then extracted by 2 individuals and then ultimately summarized in order to be presented to the expert panelists. We only took the highest, the most rigorous studies available, so we had a number of inclusion criteria. For example, in serious illness, I'm highlighting some of the main ones here. The designs had to be rigorous, prospective or cross-sectional descriptive studies, meta-analyses, randomized trials, had to have sample sizes of at least 100 and had to use validated measures. Very similar inclusion criteria for the health outcome studies, although the sample size requirement was much higher because cohort studies, in order to have adequate control for confounding, you need to have large sample sizes, so at least 1,000 patients. This is the systematic review. So from, you can see just in the gray bars at the bottom that the major part of our review occurred from January of 2000 through April 2020. You can see in very fine print here, there was about just over 13,000 articles that we had to go through. And then there was a subsequent update of the literature between 2020 and 2022. Giving for a total of nearly 16,000 papers that were reviewed. Ultimately, after we took them through all of those criteria that I mentioned to only get the best possible evidence, we ended up with 441 papers informing spirituality and serious illness. Very similar process for spirituality and health outcomes, with a total of 276 articles informing that. So these are our Delphi panelists. And just to make the point here that we had panelists that informed spirituality and public health, spirituality and serious illness. We met over multiple iterations, and obviously they were actually the ones who were combing through all that literature that I just kind of took you through as far as how it was distilled down. They were provided with standard definitions, including the one for spirituality that I've shared with you earlier today, as well as for some other related terms. So what was found? So first, spirituality and serious illness. There were 5 kind of main buckets of research findings. This is a table from the paper, and I'll just highlight to you that these are those 5 categories of evidence. So one is the role of spirituality in serious illness. A second category is spiritual needs in serious illness. Third, spiritual care in serious illness. 4, spirituality and medical decision-making, and then finally, spiritual interventions in serious illness. Just to take you through a few other details, you can see that most of the studies were from North America, but we had actually many continents that were represented with a number of studies. So, and actually in the subsequent update, it was even more kind of culturally diverse, which was great to see in the update that was done post-2020. You can see the sample sizes are on the larger side, given that was one of our requirements. So these are the 8 serious, taking all of that evidence, there were 8 findings deemed that were sort of identified by our expert panelists and deemed as supported by strong evidence using sort of strength of evidence criteria, which typically are used to inform things like medical practice guidelines and things like that. So these are the 8. Religion or spirituality are important for most patients with serious illness. Spiritual needs are common for patients with serious illness. Spiritual care within medical care is frequently desired by seriously ill patients. Spiritual needs are frequently unaddressed within medical care for seriously ill patients. Religion, spirituality can play a role in medical decision-making. For patients with serious illness, spiritual care is infrequent in the medical care of patients with serious illness. Provision of spiritual care to patients with serious illness is associated with better end-of-life outcomes. And then finally, unaddressed spiritual needs are associated with poor patient quality of life outcomes. So allow me to take a moment to give you a few examples. I'm providing you the overview evidence statements that were supported by strong evidence, and now I'm going to give you a few examples. So first example, importance of spirituality in serious illness. So this is a study of over 8,400 cancer survivors. Actually, the American Cancer Society did this study where they asked the question, my faith or spirituality has helped me through my cancer experience. And you can see here that just under 70% of all of the respondents indicated quite a bit or very much. And you can see it's particularly important among certain racial and ethnic minority groups in the United States. This next study is a smaller study, but provides an important qualitative component. This was a study of 75 randomly selected patients receiving palliative radiation at 4 Boston academic centers. They were asked whether religion or spirituality was important to their cancer experience. 78% indicated yes, it was important to their cancer experience. And after they indicated yes, we asked them, well, how? How has this been important to your cancer experience? And their answers were recorded, then transcribed and qualitatively analyzed, and these were the themes that arose from that qualitative analysis. So first, coping through one's spirituality was a very common theme. You can see that this is the gentleman that actually shared at the beginning. If it weren't for my faith, I don't know I would have kept my equilibrium through this process. The next is the common referral to important spiritual practices. This person speaking about prayer, and interestingly saying, not for myself, but for those you leave behind, and there will be a lot more praying. Another common theme was that of spiritual beliefs that are helping to ground one's understanding of one's illness. This person saying, based on my religious beliefs, I think I was given a certain number of days on this earth from day one, and I don't think that changes with my diagnosis. It tells me that if God wanted me yesterday, I wouldn't be here today. Next was a spiritual transformation, so a change in one's spiritual beliefs resulting from the illness experience. This person describing it's a transformative experience to have an illness such as this, and when you have that, you have to reevaluate all you've done in life, who you are, and who you are going to be. And then finally, the important role of spiritual communities, this person indicating that they depend upon their faith community for support. So 5 themes for how spirituality is operating in the context of serious illness, in this particular case, cancer. So functioning in dynamic ways. So next, let's consider an example of studies that speak to this question of the relationship of patient spirituality to quality of life. So this is a study, a multi-institutional study done in the United States across several centers of over 1,600 cancer patients, actually all stages of cancer. And spirituality was measured with a validated scale, the FACIT-SP, and found to be an independent predictor of quality of life, even after controlling for other key predictors of quality of life, physical well-being, emotional well-being, et cetera. One argument against studies like this is that, well, your measure of quality of life and your measure of spirituality might have some overlap, in which case, no matter what you do, you're going to find a relationship between the two because you're measuring essentially the same thing. So this study kind of nicely gets around that issue. This is a study of over 1,800 seriously ill patients, actually all types of illness, where they were simply asked, what is most important to your well-being at the end of life? And they were given 44 possible attributes. The top 9 are listed here. And for patients, being free from pain and being at peace with God, of those 44 were number 1 and number 2. And in fact, the authors in this paper note that they statistically tied for first. So a spiritual construct, being at peace or being at peace with God, really rising to the fore as what patients are naming as what is most important to their well-being at the end of their lives. So third, what about the role of spirituality in medical decision-making? This is an example study of a survey-based study of 100 patients with advanced lung cancers, their family caregivers, then 257 medical oncologists who care for advanced lung cancer patients. Each of those groups were asked to rank 7 factors important to the patient in making treatment decisions. And these were those 7 factors. All agreed, all 3 groups, that the ability of the treatment to cure the disease was most important to medical decision making. But next for patients and for families, and last for physicians was patients' faith in God. So just illustrating how, this is definitely a salient factor in patients' minds. The family understands that it's a salient factor in the patient's mind, but the physician does not see that as a salient factor. But then you have to ask, well, what does this actually impact the types of care decisions that patients are making at the end of life? And this study would suggest that it does. So this is the Coping with Cancer study, a multi-site study done in the US where they examined baseline religious coping, which remember I named coping as one of the major themes of ways in which spirituality is operative in the experience of illness. So they measured it with a validated scale, Ken Pargament's validated R-COPE scale, at baseline, and then followed patients to the end of their lives, and then looked at the types of care that they received at the end of life. So the blue bars are when patients exhibited, it was just a median split, high religious coping at baseline. The yellow is low religious coping. And as you can see, across the x-axis here, we have those in the last week of life being ventilated, so on a ventilator, being resuscitated, undergoing CPR, and then ultimately dying in the ICU. And we can see that high religious coping patients were more likely to receive all of these aggressive end-of-life measures. And this is the raw data, but even after you control for other factors, these relationships continue. So that, of course, raises the question, what in the world is going on? Why is it that these patients highly relying upon their religious beliefs to cope with illness are tending to receive greater aggressive care? One hypothesis is that there are religious beliefs in end-of-life care that are operative. And so in this study, a separate study of advanced cancer patients, 7 potential religious beliefs in end-of-life care were posed. And then patients were asked to what degree they agree with those statements and experience them in their own experience with their illness. So for example, this first one here, my belief in God relieves me of needing to think about future medical decisions, especially near the end of life. Nearly 60% of patients, any of the blue with some degree of endorsement, endorse that item. Or I will accept every possible medical treatment because my faith tells me to do everything I can to stay alive longer. Nearly 70% of patients. Here is, I believe that God could perform a miracle in curing me of cancer, also a large majority of patients. So these are very frequently endorsed beliefs in end-of-life care that are likely influencing how patients are making their medical decisions. And in fact, in this study of nearly 300 advanced cancer patients from multiple sites across the US, 87% endorsed at least one of these items, and 62% at least endorsed 3 or more. So clearly very common for individuals to have these sorts of beliefs as they're considering their own end-of-life care. So another example is that of spiritual needs in serious illness. So there are a number of studies which have addressed this in various populations. And one thing that's interesting is across populations, the frequency of spiritual needs it's always very frequent, no matter what population you're in. So I'll just provide you with a few examples. This is Alan Astro is a medical oncologist in New York City and has developed the spiritual needs assessment tool for patients, a validated scale for assessing spiritual needs, and has done this in a number of settings, but in this particular one, in over 700 racially and ethnically diverse cancer outpatients from 4 New York City sites, 59% of them spiritual, not religious. So this is an interesting population to examine, a little bit different than much of the United States. So these are just the frequencies of their needs, and I'm just going to point out a couple. Finding meaning, over half. Finding hope, similarly, majorities of patients. Personal meditation or prayer practices, 50%. Your relationship with God, over 50%. Finding peace of mind, 50%. Finding forgiveness, 40%. So in at least one spiritual need was reported by 79% of patients. I'll just take you to a different context. This is just showing that spiritual needs are actually associated with lower perceptions of quality of care and care satisfaction, just showing that it actually influences overall sort of patient perceptions of care quality and care satisfaction. In a different context, this is actually in patients with chronic illnesses and also with cancer at 2 hospitals in Germany, another spiritual needs questionnaire. And similarly, the presence of spiritual needs was quite common. You can see in a more secular population that religious needs are less common, but those having to do with these categories, they've categorized them as peace, generativity, and existential needs are very common. So although the types of spiritual needs can vary depending on the cultural setting, it's just the types that are varying, not the frequency. So finally, spiritual care and outcomes in illness. So this is a multi-site prospective study of advanced cancer patients examining psychosocial and spiritual factors and how they relate to end-of-life outcomes, including quality of life and end-of-life care. And at baseline, patient spiritual care was assessed in 3 different ways. Support of spiritual team needs by the medical team, which included all of the medical team, doctors, nurses, chaplains, et cetera. Support of spiritual needs by spiritual communities, and then receipt of pastoral care visits. And outcomes included quality of life, which was measured by a caregiver present with the patient in the last week of life, and then the medical care that was received in the last week of life. So this is the relationship of baseline reports of spiritual care and quality of life outcomes. So I'm just going to draw your attention to the bar graph over to the right, where the blue is the patient is reporting any form of spiritual care at baseline. And the orange is when no spiritual care is present. These are adjusted analyses, adjusting for types of care that they received, adjusting for baseline quality of life. And we can see the y-axis here is patient quality of life near death, with higher numbers meaning better quality of life near death. And you can see that patients that are receiving spiritual care are ultimately having better quality of life at the end of life in this prospective study. What about end-of-life care outcomes? So high spiritual support from the medical team was reported by only about a quarter of patients, but when present, those patients transitioned to hospice more frequently, they had less aggressive interventions, less ICU deaths, and the impact of medical team spiritual support on end-of-life care was largely seen in those high religious coping patients. Remember earlier I mentioned how high religious coping patients tend to receive greater aggressive care at the end of life. It's when those patients are interfacing with a team that's providing spiritual care that they become no longer likely to receive aggressive interventions at the end of life. Interestingly, high spiritual support from religious communities, which is more common, is associated with less transitions to hospice, and as you might imagine, greater aggressive interventions, more ICU deaths, and the findings are stronger in our high religious coping patients. So I'm just going to turn and spend a little bit of time on spirituality and health outcomes, just because I think it's important to bookend this topic with both in the setting of serious illness and to see the role that it plays in healthy communities. And again, there were actually 5 topic areas that arose, so I'll just highlight these to you. So the role of spirituality and its impact on outcomes like all-cause mortality, other measures of physical health, health behaviors, mental health, and quality of life. Again, we have representation, it's majorities from North America, but also representation from many other continents, very large sample sizes from these large public health cohort studies. There were 8 health outcomes that were found to be, that were named and believed to be supported by strong evidence by the panelists. So frequent service attendance is associated with a lower risk of mortality. Service attendance is associated with less smoking, use of alcohol, and marijuana and illicit drugs among adults. It's positively associated with better quality of life. It's associated with better mental health outcomes. There's even a dose-response association between service attendance and lower risk of mortality. Frequent service attendance is associated with less smoking, risky sexual behaviors, alcohol, and other drug use among adolescents. It's associated with less depressive symptoms, and it's also associated with less suicidal behaviors. So I'm just going to pictorially just give you a sense of that. It's quite amazing how there are strong findings as far as spirituality and having community involvement having sort of spiritual communities of meaning resulting in lower mortality in very robustly done, controlling for confounding studies. There's even sort of a degree of the more involved you are, the more it impacts one's outcomes, including longevity, better quality of life and life satisfaction, less smoking, alcohol and drugs, better mental health, less suicide, less depressive symptoms, and for adolescents, less risk behaviors. And I'm just going to provide you, just like before, a few examples of these studies. So in all-cause mortality, this is a large study, over 120,000 individuals, showing a 27% reduction in all-cause mortality among those that are highly involved in religious communities. As far as health behaviors and mechanisms, twofold higher odds of smoking cessation for those that are highly involved in religious communities, also about a third reduction in illicit drug use for adolescents. Disease-specific mortality, so less reduction in cardiovascular disease mortality, as well as a reduction in cancer mortality. And then finally, in mental health, about a quarter reduction in depression incidence, and an 84% reduction in the incidence of completed suicide. So many profound kind of impacts on the overall health of communities. And so based on these findings that I pointed out to you both in the setting of serious illness and now in the setting of healthy populations, the expert panel also set forth kind of what are the implications of this for healthcare, both when we're caring for patients who are seriously ill, and then also when we're caring for healthy populations. And these are those implications. So first, in regard to in the setting of medical care for those who are seriously ill, it's to first, the highest ranking sort of recommendation was to be routinely incorporating spiritual care into the medical care of patients with serious illness. Next was that spiritual care education should be provided to all members of the interdisciplinary medical care team caring for those patients. And that we need to include specialty practitioners of spiritual care, such as chaplains, in the care of patients with serious illness. What about health outcomes? Very sort of analogous findings here, which is one, that we need to incorporate patient-centered approaches that pay attention to, that acknowledge the important impact that spiritual community participation has on health, on population health. There also needs to be education so that there's improved awareness among public health professionals regarding the impact of spiritual communities on health. And then finally, spirituality should be recognized as a social factor associated with health and research and community assessments, and then program implementation. So just to pictorially summarize, where we've kind of traveled today, I spoke first about how in the past, and medicine was kind of born, Western biomedicine was born within spirituality and medicine being quite integrated with one another, and that resulted in care having a very integrated focus on both the spiritual health of patients as well as bodily health. But that's changed. There's been a division of the two, and care has been largely focused on the body, much to the benefit of our understanding of how to intervene on the health of our patients and to alleviate suffering, but also can lead to the neglect of key aspects of what it means to face illness and also to be healthy. And so we're moving towards spirituality and medicine being reintegrated, where we do indeed have care that has a combined focus on both individuals' bodily health as well as their spiritual health. So to summarize, spirituality really only recently has been disconnected from medicine, and this really does have implications for our care of patients. It has implications for us who care for patients, and it also has implications for whole healthcare systems. Evidence points to the importance of spirituality in serious illness, as I've described to you, and also in the health of communities. And really, whole person care requires the reintegration of spirituality into medicine. And it's really our task to carry that forward, and even kind of experiencing sort of the culture here in your own facilities. Clearly you have that heritage and that desire to really carry that forward and provide meaningful models that even can teach others in how to be caring for patients in a holistic way. So thank you all for your time and attention, and I'll open it up for questions. Yes?
So this may fall whole field of what your major premise is, but something that struck me was the difference in the dichotomy between the patients and the providers, and the answers from being first and second and being seventh for physicians.
Yeah.
Has there been any look at how those that care for seriously ill patients, the impact of spirituality and resilience, and how we care for patients and how we do as caregivers?
So there's been some, there is like important work, not as kind of in-depth, more work to be done on clinicians and the role of spirituality in resilience, and also in, in preventing burnout. And definitely there's a role. There's a role in prevention of burnout. And there's certainly a contribution to resilience. How to like support that and to enable that to uphold resilience and to help mitigate burnout, I think is yet to be determined. I think that there are some that are doing some work in that regard, but I think really an important area. Yes.
You touched at the end of your presentation on public health,
Yeah.
and responding really to how we manage populations.
Mm-hmm.
I'm thinking the American Academy of Pediatrics has declared mental health a state of emergency, and we have a lot of substance abuse challenges and high suicide rates. In 2000-ish, Mr. Nixon really stepped up on prevention.
Mm-hmm.
We started rolling the first mobile prevention units into the community.
That's great. Huh?
Do you see health systems that are doing this improved access, public health work related to spiritual care? We have Stacy Cohen here who leads our faith and health ministry, but at the community level, what do you see communities doing?
Well, there's definitely some work, and maybe I'd love to hear from the person that does work in faith and interfacing with faith communities, and in working with faith communities to do some of that work in prevention, and to be reaching out, in particular to certain communities where those faith communities can be some of the strongest advocates, and so that's one method, is actually working in partnership with faith communities. One other issue I would just is clearly an area that needs to be kind of opened up and further examined and then impact public health, et cetera, is, it's interesting, you see, religious community participation is declining in the US. And if you follow suicide rates and loneliness rates, they're going up at the same time. And I'm not, it might not be right and good for people to have a religious community that they're affiliated with, but communities of meaning are really important for people, and that might look different now. It might be a religious community for some, it might be something different for others, and advocating for and building ways that individuals, and especially adolescents, coming into this world with, in the past, people grew up in communities of meaning. You had a religious community. That's what you had. That was what most cultures had. And children are growing up largely without that larger structure to uphold a sense of meaning, purpose, and value in life. And you can see why that creates issues with substance use, issues with mental health, and ultimately with suicide. So all of those things are potentially intertwined together, and I think would be important, especially as one considers population health, health of children and adolescents, an important area to examine and to uphold. Right now, public health in general, like for many, at least this is my kind of narrower experience, it sounds like perhaps you here have a different experience. There hasn't been a lot of engagement of faith communities as part of a public health model, partnerships and things like that. That's been my own experience working up in Boston. There's a little bit, but not much. It sounds like you all might have more here. Go ahead.
Over the years, I've noticed the dramatic increase in, not a great word, but productivity. We want to get patients in and out. And so taking that extra time between physician and patient, there's pressure to get from one patient to another. Has there been any integration of Gestalt pastoral care within these findings, within this study that you know of, or is Gestalt pastoral care being introduced into the healthcare system at all?
So, just one kind of study that comes to mind of a setting where you definitely have clinicians that are just hard pressed and going from patient to patient would be like in ICUs, for example. And definitely there's some strong data from the ICU setting that when you have pastoral care providing care to those typically it's families, patients and families, but often largely the families, that they have, like overall better care satisfaction, et cetera, when that's present. So I think there is a potential, that would be just what's one setting, but one could argue that there is a potential role for that. That being said, you worry a little bit about, yes, there's time pressures that we have to take into consideration, and to some extent we can't eliminate those, but I worry about clinicians who are stuck in settings where they have hardly any time to actually engage with the human elements of each of their patients and what that does to them, not to mention the patients. So although we could maybe offset it by providing more pastoral care in those settings, things like that, I also would want to push back on structures that take away some of the key element of what's required to have a human relationship as part of care, particularly in the setting of things like cancer care, et cetera.
And to follow up, specifically Gestalt illness, with the interdisciplinary team as well. And so the patient and the team they become a unit.
Yeah. No, I agree. It's wonderful. Okay.